So welcome med geniuses. We have talked about the axilla, we have talked about the cubital fossa. So now we'll be talking about the carpal tunnel. So if you have not watched them yet, go and watch them before you come here. Or specifically, if you want this video, you can stay to the end. Make sure you stay to the end because we'll be talking about some important parameters that will be useful for your exams. If you are just new joining us, make sure to go and subscribe. Turn on that post notification button. So make sure punch that subscribe button. Turn on the post notification button so that anytime I drop any video, you'll be sure to be notified. And if you have not watched most of my video, you can start from the beginning. The bones of the upper limb, the muscles of the upper limb, the nerves of the upper limb, which is the brachial plexus, before you can come here, so that you can appreciate the video and understand it very, very well. So if you want me to make a specific topic for you, drop it down in the comment section. When I go to it, I'll make sure to make that topic for you. So let's jump right into the video. So welcome guys to another video on the space in the upper limb. In my last video, we talked about the cubital fossa, and we have talked about the axilla. These are important spaces in the upper limb because the axilla helps to transfer neurovascular structures from the head region to the arm. The cubital fossa helps to transfer neurovascular structures from the arm to the forearm, while the carpal tunnel now helps to transfer neurovascular structures from the forearm to the hand. So it's very, very important. So watch them in rows like this so that you understand them very well. So what is the carpal tunnel? So the carpal tunnel is a tunnel-like shaped space or an oval-shaped space that transfers neurovascular structures from the forearm to the hand. It is a deep palmar arc before. It's a deep palmar or carpal arc before, formed by the boundaries of the carpal bones. But with the help of the thickness of the deep fascia, which is the flexor retinaculum, that bridges the deep palmar arc or the deep carpal arc, it converts it from an arc to a tunnel. So the carpal tunnel is an arc, is a deep carpal arc formed by the boundaries of the carpal bones. But when the thickening of the deep fascia crosses the arc, it converts it from an arc to a tunnel. Now, what are the boundaries of the carpal tunnel? So I've told you before, it was a deep palmar or carpal arc. Then due to the flexor retinaculum bridging the roof of the carpal arc, what happens? It converts it to a carpal tunnel. So what are the boundaries now? The boundaries now, we have the roof. So if you are inside the carpal tunnel now, imagine yourself being inside the carpal tunnel, just like the one you are seeing on your screen. What will be on the roof of the carpal tunnel? Like I said, the deep fascia. What is the deep fascia? Flexor retinaculum. So there's a part that is sticking in the deep fascia. That part that is sticking in the deep fascia, crossing the carpal bones, are called the flexor retinaculum. What is the floor? The floor is the carpal bones. What are the carpal bones? We have the proximal carpal bone, we have the distal carpal bones. The proximal carpal bones is she looks too pretty. What is she looks too pretty? Scaphoid, lunate, tracheotomy, and pisiform. The distal carpal bones try to catch her. What is try to catch her? Trapezium, trapezoid, capitate, and hamate. They form the floor of the carpal tunnel. Now, what is located laterally? So lateral is the scaphoid and the trapezium. What is located medially? Medially is the pisiform and the hook of hamate. Don't forget. Now, lateral is the scaphoid and the trapezium. Medial is the hamate and the pisiform. Roof is the flexor retinaculum. Floor are the carpal bones. So the next we'll be talking about the content of the carpal tunnel. What are the content of the carpal tunnel? Now, there are some structures that passes inside the carpal tunnel, which is deep to the flexor retinaculum, while some structures passes above the flexor retinaculum. We'll be talking about them one after the other. Now, deep to the flexor retinaculum, there are 10 structures that passes there. 9 tendons and 1 nerve. 9 tendons and 1 nerve. So what are the 9 tendons? Now we have 4 tendons of the flexor digitorum superficialis. We have 4 tendons of the flexor digitorum profundus. And we have 1 flexor pollicis longus. So 4 flexor digitorum superficialis and profundus, 1 flexor pollicis longus. And you have 1 nerve. And what is the nerve? Median nerve. Now, since we know the 10 structures that passes through here, now we have some structures that passes above the flexor retinaculum. So what are the structures that passes above the flexor retinaculum? Now, the first one you have is the ulnar nerves and vessels. So always remember that the ulnar nerves and vessels do not pass inside the carpal tunnel, which is deep to the flexor retinaculum. They passes above the flexor retinaculum. So we have the ulnar nerves and vessels. We have the palmar-cutaneous nerve of the ulnar. We also have the tendons of palmaris longus. Palmaris longus insert on the flexor retinaculum. It doesn't pass under, just like other tendons of the flexor compartment of the forearm, which is called the anterior compartment. The next one is the palmar-cutaneous branch of the ulnar nerve. All palmar-cutaneous nerve do not pass inside the carpal tunnel. They pass superficial to the carpal tunnel, which is superficial to the flexor retinaculum. The last one, superficial palmar branch of the radii artery. So superficial palmar branch of the radii artery also pass superficial to the flexor retinaculum. So we say 10 structures passes deep to the flexor retinaculum, 6 structures passes superficial to the flexor retinaculum. So the next thing we'll be talking about is the clinical scenario or the clinical factors or the clinical correlation of the carpal tunnel. So what is the clinical scenario of the carpal tunnel? The first one is the carpal tunnel syndrome. So you call it the carpal tunnel syndrome because here there is a compression of the carpal tunnel. So when you compress the carpal tunnel or the flexor retinaculum, what happens? You compress the median nerve. And when you compress the median nerve, what comes with the compression of the median nerve? First of all, there will be numbness because it's a mononeuropathy. Why? Because it's a single nerve you are compressing. That's why we call it mononeuropathy. And what comes with neuropathy? Because neuropathy is when there is any damage to a nerve. So when you are damaging a nerve or when you are occluding a nerve, what happens? There will be what? Numbness in that area because the nerve transmits signals for movement. So when there's no movement, usually motor and sensory, what happens? There will be what? Numbness there. The next one now, there will be tingliness, just like a pinprick sensation. The next one, there will be pain around the distribution of that nerve. So you will surely see pain there. And again, it always comes radiating to the forearm. So usually the median nerve always innervate muscles around the forearm. So you'll be seeing what? Pain distribution around that innervating part. Also, when you are waking them from sleep, what happens? They will be feeling this pain, especially in the morning. So wake them from sleep, they jack up, what happens? They'll be feeling that pain and the pain gets worse in the morning. So these are clinical scenarios or clinical presentation you see. You know that this patient have what? Carpal tunnel syndrome. So one, when you wake them up from sleep, they will feel pain and it's usually worse in the morning. It will radiate to the forearm. There will be numbness and tingliness in the areas of the forearm and that part of your wrist. Also, since it's innervating muscles of the intrinsic part of the hand, what happened? Especially the tendon muscle, what happened? There will be tendon wasting. So if you tell the patient to show you their palm, what happens? You'll be seeing the wasting of the tendon muscle. The tendon muscle will not be bulky. It will just be wasted like you see in your screen now. So when the tendon muscle is wasting, you're able to flex the forearm at the wrist joint. So how can you confirm it's carpal tunnel? There's what we call the tennis signs. So what is the tennis signs? You are seeing it on your screen where you tap the median nerve at the carpal tunnel. So if you tap the median nerve at the carpal tunnel, you'll be seeing pain. There will be elicitation of pain around the distribution of the median nerve. Also, you have the Filings maneuver. What's the Filings maneuver? Hold the wrist in flexion for 6 minutes. Then when you are holding it in flexion, what happens? There will be pain in the median nerve. So how do you treat? You can treat with what? Splinting, and also do a what we call a passive mobilization of the wrist joint. So when you passive mobilize the wrist joint, what happens? Especially overnight, and you can also give corticosteroid too. Corticosteroid is used to inhibit inflammation. So you give corticosteroid, you do massive physiotherapy, you use a splint. When you use a splint, you do passive mobilization. Then you can also stretch that place too. So it can also help to reduce pain. So you can also use some electrical modalities. If you don't want to use corticosteroid drugs, you can use some electrical modalities like TENS, infrared, and many stuff to help reduce. So I hope it all makes sense to you and you understand everything I've talked about in the carpal tunnel, where we start with the introduction to the carpal tunnel, how it converts from an arc to a tunnel, through the help of the flexor retinaculum, and we talked about what passes deep to the carpal tunnel and what passes superficial to the carpal tunnel. So we talked about everything, and we also talked about the clinical scenarios, which is the carpal tunnel syndrome. So I hope you understood it. So make sure you watch my muscles of the forearm video so that it will be much more easier for you to understand the carpal tunnel. So hope you understand it. So always like, subscribe, and share my video always. And if you want, or you do, and if you do not understand, just make sure to drop it down in the comment section, and when I review it, it's either I make the video again or I explain it more. Or if you want me to make any video for you, so also write it down in the comment section. I promise to make that video for you. Also use your atlas to read. Make sure you see the picture so that you understand them very well. So I'll see you in the next video. Bye bye.